Hello and welcome to the Comp Pod. I'm Andy.
And I'm Ivy. Thanks for joining us.
If a single tornado touches down in North Carolina today, a worker recovering from a shoulder injury in Ohio might actually not be able to get their generic pain medication like 3 months from now.
It sounds totally absurd when you put it like that, but that is the reality of modern medical logistics. I mean, we look at a little orange pill bottle and we just assume it's a localized product.
Right.
But it's really the endpoint of a highly sensitive, incredibly fragile global web.
Which is exactly what we are getting into today for this deep dive. We have a fantastic article on the table called Coming Up Short, When Drug Shortages Become a Claims Problem.
Yes, published by Healthy Systems.
Exactly. And, for anyone listening who interacts with healthcare, claims management, or just wonders why their pharmacy occasionally comes up empty, this is a must-read.
Oh, absolutely.
We're looking at how global supply chain disruptions, like the massive events you see on the international news, end up creating these incredibly complex puzzles for claims professionals right here at home.
Yeah, the mechanics of how a global event filters down to a single prescription counter are truly fascinating. And to really understand how these shortages turn into an administrative labyrinth for claims teams, we first have to look at the current landscape of drug availability in the U.S.
Right.
Because as of 2026, the data presents a massive paradox.
Well, let's get into that paradox because the scale of this is not small.
Yeah.
I know the American Medical Association is currently calling drug shortages an urgent public health crisis.
They are.
And just so we're all on the same page, the FDA defines a shortage simply as a situation where supply isn't meeting current demand or even forecasted demand.
Exactly.
And as of June 2026, the FDA is tracking 73 national drug shortages.
73 active national shortages. But when you look at the historical timeline, this strange picture emerges. The number of new incident shortages is actually plummeting.
Wait, really?
Plummeting. Yeah. If you go back to 2011, which many consider the peak of the shortage crisis, we saw 267 new drug shortages in that single year. But by 2025, that figure had dropped to just 89.
Okay, that's a massive, that sounds like an absolute win for the pharmaceutical supply chain. So why is the AMA still calling it an urgent crisis today?
Because while the supply chain is breaking less often, when it does break, it stays broken for a much, much longer period.
Oh, I see.
The duration of these shortages has stretched out significantly. According to the data, more than half of all the active shortages tracked by the FDA in 2024 had been ongoing for over 2 years.
2 years. Okay, so instead of thinking about this like a leaky roof where the number of leaks is going down, it's more like a highway system. We've successfully reduced the number of minor fender benders happening every day. But the accidents we do have now involve massive overturned semi-trucks that block all lanes of traffic for miles.
Yes.
And they take years to clear. So the actual congestion for the driver, or in this case, the patient, is actually worse.
That is a brilliant way to visualize it, yeah. The frequency of the disruption has dropped, but the severity and the duration have spiked. And the sheer volume of patients caught in that traffic jam is staggering.
Yeah, the numbers are huge.
An average drug shortage affects 500,000 consumers.
One shortage hits 500,000 people. That's wild.
Yes, and there is a specific category of medication taking the absolute brunt of this. The Healthy Systems article points out that 84% of these multi-year shortages involve generic drugs.
84%.
Yeah. From 2018 to 2023, we saw over twice as many generic shortages as brand drug shortages.
Which is incredibly consequential considering generics are, essentially the foundation of day-to-day healthcare.
Yeah.
But I'm struggling to understand the mechanism here.
Sure.
If demand for a generic drug is high and a shortage lasts for over 2 years, what is actually causing the system to stay blocked for that long? Where is the initial break happening?
Well, the FDA tracks a few primary drivers for these bottlenecks. The most common culprit they identify is manufacturing quality issues. But that's closely followed by production delays at the manufacturer, or delays in getting the necessary raw materials, sudden spikes in consumer demand, or even instances where a manufacturer just decides to discontinue a drug entirely.
Here's where it gets really interesting for me. We tend to imagine pharmaceutical manufacturing as this perfectly controlled, isolated scientific environment.
Right, the pristine white lab.
Exactly. Pristine white labs, untouched by the outside world. But ultimately, this is a physical manufacturing process reliant on physical infrastructure. which means it is totally exposed to the elements.
It is entirely exposed. Let's go back to that North Carolina tornado you mentioned at the start of the deep dive. That wasn't a hypothetical.
Oh, right.
In 2023, a tornado severely damaged a Pfizer pharmaceutical plant in North Carolina.
And a single building taking storm damage caused a national ripple effect.
A massive one, because that single facility was responsible for producing nearly 25% of all sterile injectable medications used in U.S. hospitals.
25%. That level of consolidation is wild.
It is a classic double-edged sword. Manufacturers consolidate production into these massive, centralized facilities to achieve economies of scale.
Which keeps the cost of those generic drugs down, I imagine.
Exactly. But in doing so, you concentrate all your physical risk into one geographic footprint. The building loses its roof in a storm, and suddenly hospitals across the entire country are looking at empty inventory shelves.
And weather is just one variable, right? Because the healthy systems piece also dives into how international trade routes create these choke points, particularly for the raw materials.
Oh, geopolitics is a huge factor. This brings us to the February 2026 closure of the Strait of Hormuz.
Right, due to the conflict between the U.S. and Iran.
Yes. And from a purely logistical standpoint, this is one of the most critical maritime choke points on the planet. The United States relies heavily on that specific strait for the transit of both the raw, active pharmaceutical ingredients and the finished drug products.
And because nearly half of all generic prescriptions in the U.S. originate in India, a bottleneck in that specific region immediately threatens the generic supply.
Precisely. A shipping lane closes, cargo ships are rerouted or delayed, and suddenly those raw materials aren't hitting the manufacturing plants on time.
Which triggers the exact FDA drivers we just discussed. Delays in raw materials leading to production delays, leading to a massive shortage.
Exactly.
It is mind-bending to trace the causality. A maritime bottleneck halfway across the world eventually results in a missing pill bottle in an Ohio pharmacy.
It really is.
Now, if generics are the most vulnerable point in this supply chain, that has to cause absolute chaos in healthcare sectors that rely on them almost exclusively. Which brings us to the workers' compensation system.
The workers' comp system is uniquely exposed to this. As of 2023, the rate of generic utilization in workers' comp was 89%.
So they are heavily indexed on the exact category of medication that is experiencing these multi-year systemic shortages.
Right. It is no surprise then that 46% of workers' compensation industry stakeholders now cite medication or provider shortages as a top challenge.
I can imagine.
And for medical program managers specifically, navigating these shortages is their #1 operational challenge right now.
Are they dealing with the same types of drug shortages as the rest of the healthcare system? Because the FDA data from June 2026 shows that pediatric anesthesia and cardiovascular drugs are the leading therapeutic areas for shortages globally. But workers' comp is treating a very specific type of patient, usually adults recovering from workplace injuries.
That is a crucial distinction. The macro FDA data doesn't perfectly mirror the micro reality of a workers' comp claims desk.
Okay, so what does the data look like for them?
If you look at IQVIA data from 2024, national drug shortages were highly prevalent in pain management and oncology. Pain and anesthesia medications have consistently been among the leading causes of shortages over the past decade.
And pain management is obviously a massive component of helping an injured worker recover from an accident or subsequent surgery.
Exactly. When those specific drugs vanish from the shelves, there are immediate impacts on the claim.
What kind of impacts are we talking about?
The Healthy Systems article outlines a couple of primary effects. First, there's an increase in costs, as the prices for available substitute drugs often jump significantly.
Right.
And second, there are slight delays in the actual treatment timeline while the care team searches for an alternative.
I want to briefly touch on those impacts, but I really want to focus on the underlying friction. Because increased costs and slight delays sound like standard business hurdles,
Yeah.
But the reality is this creates a disproportionately massive administrative headache for the claims teams managing that worker's recovery.
Oh, definitely.
So why is substituting a missing generic so much more complex in workers' comp compared to standard group health insurance?
To understand the administrative burden, we have to look at the structural rules of the workers' comp system. It is fundamentally designed to protect the injured worker, which means it operates under very unique regulatory frameworks.
Right.
For starters, in the majority of states, injured workers have the right to choose any pharmacy they want.
Which usually means they are just going to the pharmacy closest to their house or the one attached to their grocery store, entirely based on convenience.
Yes. So if that specific neighborhood pharmacy is out of stock of a prescribed generic, the claims team doesn't have the authority to simply mandate, hey, you must drive 20 miles across town to this other pharmacy because our inventory data says they have it.
Oh, wow, okay.
Yeah, the payer's ability to direct care based on supply chain availability is highly restricted.
So the worker is standing at their local pharmacy, and the drug is out of stock. In the normal retail world, the patient might start calling around to other pharmacies themselves to find it. Why doesn't that happen here?
Because of the financial structure. In workers' comp, the payers absorb 100% of the prescription costs for the approved injury. The injured worker doesn't have a copay. They don't have a deductible for that specific claim.
Which is excellent for the injured worker. But from an operational standpoint, it means the patient has zero financial incentive to actively manage the supply chain problem.
Precisely.
If the generic is gone, they aren't going to spend their afternoon comparison shopping or seeking out alternatives because they aren't foot in the bill anyway.
And that drops the problem squarely onto the desk of the claims professional. Now you might think, okay, the generic is out, just substitute it with a similar drug or the name brand.
Right, that sounds easy enough.
But that brings us to the regulatory layer, state-specific formularies.
Let's unpack the mechanics of a formulary, because it's not just a casual list of suggestions, right?
No, not at all. It is a highly codified set of treatment guidelines. These formularies dictate exactly which medications are approved for specific injuries at specific stages of recovery. They are built to ensure medical safety and control costs under normal functioning market conditions.
But when a global shipping delay means the approved drug simply doesn't physically exist in the state of Ohio, that rigid safety system suddenly becomes a massive roadblock.
Precisely. You can't just casually swap a pill at the counter. A substitution often triggers a formulary edit or a rejection.
So what happens then?
Well, to get an unlisted alternative approved, you now have to initiate prescriber outreach. The doctor has to be contacted, a new medication has to be evaluated against the guidelines, a new utilization review might be required, and fresh approvals have to be routed back to the pharmacy.
Wow. So what does this all mean for the claims professionals? It's like trying to rebook a canceled commercial flight, but every single passenger is bound by a completely different state-legislated set of ticketing rules.
That is an incredibly accurate comparison.
Yeah, you have to individually negotiate every single rebooking with the airline, and you are paying the premium for whatever seat is left.
Exactly. A drug shortage transforms a completely routine, low-touch claim into one that requires intense, high-touch manual intervention. The administrative friction of just trying to find a safe, approved alternative prolongs the entire life cycle of the claim.
So how do you solve that? Because, I mean, a claims adjuster can't control global shipping lanes, and they can't prevent tornadoes. So if the physical supply chain is this fragile and the regulatory environment is this rigid, how do organizations keep these claims moving without requiring a human to manually intervene on every single out-of-stock prescription?
The industry relies heavily on proactive operational solutions, primarily through deep partnerships with pharmacy benefit managers.
Okay, PBM.
PBMs. The PBMs serve as the operational bridge between the complex regulations and the reality of the pharmacy counter.
Let's dive into the mechanics of that. What does a PBM actually do when a worker hands a prescription to a pharmacist for a drug that is, say, currently sitting on a cargo ship delayed in the Strait of Hormuz?
The first line of defense is providing immediate, automated guidance to the pharmacist at the point of dispensing. PBMs utilize real-time drug utilization reviews, commonly known as DURs, alongside step therapy algorithms.
How does that algorithm actually function at the counter?
When the pharmacist enters the prescription into their system, it initiates a digital handshake with the PBM's database. If the prescribed generic is flagged as out of stock or caught in a shortage, the step therapy algorithm doesn't just issue a hard rejection.
That's good.
Instead, it instantly analyzes the state's formulary, the specific injury guidelines, and current inventory data to suggest a clinically appropriate, evidence-based alternative therapy right there on the pharmacist's screen.
That is brilliant. So instead of the pharmacist turning to the patient and saying, hey, we don't have it, you need to go call your doctor and figure it out, the system is actively providing the solution in real time.
Exactly. It prevents the entire recovery process from grinding to a halt over a supply chain hiccup. And this is entirely dependent on real-time adjudication and messaging technologies. The speed of the data transfer is what keeps the patient from leaving empty-handed.
It is a phenomenal look behind the curtain of modern healthcare. The Healthy Systems article really highlights how interconnected our world is and how a claims professional is essentially managing localized fallout from global events every single day.
The vulnerability of these supply lines demands that level of operational sophistication.